So today we're going to talk about anatomy of an article. So this is kind of just a low-key talk. Relax. Okay, this is not a pre-test. There's no post-testing either. So this is pretty straightforward and pretty basic. We're going to talk about the components of an article and what you can look for in each part of the article, with the benefits of each component, and when you're critically reading journal articles, how to kind of go through each section and what to look for. We'll discuss some of the language that's used in publications, and then we'll learn how to assess the completeness of an article. So, for example, if you have to prepare an article for Journal Club, raise one framework as to how to do it, and really the handout can be a checklist that you use when you're going through an article. So each section of the article makes its own contribution to describing the research. We'll look at what those contributions are. This also serves as a framework to critically read articles and learn how to critically read them. So it's beneficial if you're critically reading an article. For example, you're trying to select what article to read to learn about some topic. Also, it's beneficial if you're preparing for a journal club, or also if you're going to write a paper. It's helpful to have this framework as to what each component of the article should be saying. And it's pretty straightforward, pretty basic. So first, how do we keep up with the literature? How do we keep up with what's new? So there are a number of options as to where we can look for information. One of them is we can read textbooks. We can look at the books. There's a book by the window. It's probably serving some other purpose, not being read. These big books are used as paperweights and to flatten things, keep the doors open. So what's a major shortcoming of textbooks, especially printed textbooks? Right. They can be out of date pretty quickly, especially as we have so many advancements in all medical fields. You can look for information to learn from some of these fancy handouts that you might see, or you shouldn't see them here, you might see elsewhere, from some of the drug companies. These glossy, nice pictures, and everything looks very pretty. What would be a shortcoming of using that as information to guide? Of course, right. They're not going to tell you something that's negative. They're going to highlight what's positive. They're not going to be telling you about good things about a competing product or alternative treatments. So it's certainly biased. You can look at online references such as UpToDate and other ones that are updated pretty frequently, and most of these are non-biased. They have a group of reviewers who kind of look through each topic. And then we can look at journals. We can read journal articles. And there are some journals that are not peer-reviewed. So the journals, the worthy journals, are peer-reviewed. So what does it mean to be peer-reviewed? What's the peer review process?
Prior to publication, you have a select set of authors or editors that would review your article for any corrections or any potential bias or shortcomings in the article's conclusions.
Okay, good. So it's usually a peer review process means they're peers who are knowledgeable about the material. Hopefully they're experts in the area. And they review the article for its content, for its fairness, if it's not biased. Some journals will have others review the article for statistical purposes to make sure that you apply the right statistical test. So it's a process that hopes to ensure that when something is published, it's really worthy of being published and it's not biased. But still, there can be biases in what you read. There can be some publication bias that someone who may not submit a negative study. The journal may not print a study that may be negative or doesn't say that much. So just because you read something doesn't mean that's all the literature that's out there. So if we keep up by reading articles, this could be a daunting task. If we want to really keep up, back many years back, in 1979, there were two authors that estimated that there were 2 million articles published annually in the biomedical literature. And they calculated that if you made an effort to keep up by reading 2 articles a day, and that's a lot, if you really discipline yourself to read 2 articles a day, in 1 year you'd fall 55 centuries behind. So it's really, you might as well just give up. I mean, you can't be reading that. So if you wanted to read everything in the biomedical literature, you have to read over 5,000 articles a day. So obviously it's not possible to keep up and do anything else, like go to work, do anything else. But not all of these were medically relevant. That was the biomedical literature, not necessarily be in the medical field that's of relevance. And those were not all high quality studies. So randomized clinical trials have become the gold standard for most clinical evaluations when they can be performed. And we'll talk another time, another day, we'll talk about clinical trials. So you want to look at how many clinical trials have been published. So there's really been an exponential growth from the 60s to now. And in the 60s, in 1965, there were 39 clinical trials published in the medical literature. And in 2018, there were 26,000. And it's estimated that every 10 years, the number doubles. So there will be over 50,000 randomized clinical trials published in a year now. And if you were to try to keep up with the randomized clinical trials, you'd have to read about 800 a week, or over 100 a day to keep up. So there's a lot in the literature if you want to keep up with all fields. We kind of try to be selective and not read everything. We want to read more about what's in our field. We want to read well-conducted studies. So we need a way to tell a good study from a bad study and be selective in what we read. It's also important to know how to critically read the literature because we're all lifelong learners. This is how we are going to keep learning for the rest of our lives, and we want to be able to tell quickly if it's a good study or a bad study and not waste our time reading a bad study. We also don't want to make decisions on treating based on a faulty study or a bad study. So there are many reasons to know and to kind of have some concept of how to critically read the literature. So when we look at an article, there are these basic components, those basic sections of an article. There's the abstract, the introduction, the methods, results, discussion, and references. We'll touch upon each of these. So the abstract is an abbreviated summary of the study. The components of the abstract include what the purpose of the study is, what the methods were, the results, the conclusion. There may be biases in how the research is described and presented in the abstract, and it may not be relevant. It may not be apparent to you if you're just reading the abstract. That's one potential when you're just reading a small synopsis of the study. In addition to providing a brief summary, looking at the abstract can tell you whether it's worthwhile to read the whole article. So if it's something you want to learn more about, you can look at the abstract, and if the abstract gives you the information that you're looking for, if it starts to tell you the information, then you may want to learn more by reading the article. So what kind of information would you want to get from the abstract before you know that it's worth reading the article or not? So one of the first things that you want to know what the objective of the study is, what they were looking to do. You might want to know what the study design is. Who is included in the study? You want to see, is this a relevant population to a group that you're seeing in the office or the clinic or in the hospital setting? What they actually did, what the results were, and what the conclusions were. So this is kind of some of the information you might quickly want to get from looking at the abstract. And there are basically two types of abstracts you're probably going to see in the literature. The one on the left is the traditional abstract, which is just a summary that's all very verbal about what the study sought out to do, what the findings were, what the conclusions were. And then there's a structured abstract that's used in some journals that has all of these categories that are filled in. And this allows you to answer the questions that we just had before about each component, and so you don't have to read through the whole abstract to find what the objective of the study was, what the conclusions were, what the interventions were. So the traditional abstract is shorter. You should be able to read the entire abstract in a PubMed or when you're looking online to learn doing literature search. The longer one, the more structured abstract, is longer, and sometimes it gets truncated or abbreviated in some citation services. So sometimes it's too long to read the whole thing, and you can't even read the conclusion. So this is one downside to this type of abstract, even though when you read the whole abstract, you can get a lot more information and quicker than by reading the shorter one. And usually if you're writing a paper, the journal will tell you how they want the abstract to be. It's not that you have a choice. It's when you're writing a paper, before you set out to write the paper, there are guidelines for authors that you would read that would tell you exactly the format that how to submit the paper. So the introduction, that's the first main section, states the purpose of the research and the problem. And this is important in determining whether the authors have succeeded in answering the question they set out to answer. It establishes the importance of the research, and a key part of the introduction is a brief literature review. So it's a focused review on past literature that helps put the question that the authors are looking at into perspective. And then there's usually a statement of the hypothesis that the authors are looking to do. They may say, therefore, we set out to look at such and such in such and such population. And where is that sentence usually found? The end of the introduction, right. It's usually towards the end of the introduction is after they give you the background as to why this is so important to be studying and what others have found. They usually say, therefore, we sought to do such and such. The next section is the methods. We'll touch upon some of what to look for in the methods. This is the most important part of the article because a poorly conducted study with a flawed methodology is not worth anything. So, and you can have results that are significant, statistically significant results, but if it's from a poorly done study, it really may not carry any weight. The results, the method should be described in significant clarity and detail so that the reader can reproduce the results. Sometimes there's just not enough space for the authors to put that all in. And it should include an explanation of the experimental design, the study sample, which are the subjects, the treatment, how the treatments were allocated, blinding, what variables were looked at, and what the statistics were used. So we're going to touch upon some aspects of experimental design. We'll hear more about this in the future. But basically, an experiment can be cross-sectional or longitudinal. In a cross-sectional study, the observations are made at one point in time. This is usually helpful for epidemiologic studies. It's used to establish a relationship but cannot show cause and effect. So to have cause and effect relationship, you have to show that the cause preceded the effect. Here you're measuring everything at one time, so you can't prove that. These are usually simple and cheap and quicker studies to do. You can get an answer quickly. You don't have to follow subjects over a long period of time. So longitudinal studies can be either retrospective or prospective. Retrospective studies have subjects with a disease who are examined for some common factor in their history. This would be a case of something. If the study also examines subjects without the disease, and then you're looking for some common factor, this is the control group. This would be a case control study. And this is subject to chart review, memory recall, and with a variable quality of data. So you're working backwards. It's difficult to determine how comparable the cases and controls were. You can't establish cause and effect. But this type of study design is well suited for rare diseases because you already have the cases, the subjects who have the condition. You don't have to wait a long period of time for subjects to develop a rare disease. So if you already have a population with a rare disease, this, even though it has some flaws, can give you answers quicker than some of the other study designs. So prospective study follows subjects forward in time for development of an outcome or disease, and that can take a long time. If you have a group that you're following and who are similar in all regards, but they lack one particular risk factor, then this would be a controlled observational trial where you're following subjects who have one risk factor, subjects who do not have that risk factor, and following them for development of an outcome. And you're not making any intervention, you're just following them. So that's a controlled observational trial. If you intervene, if you give a treatment for the specific purpose of a study, then that becomes a clinical trial. And if you have a control group that doesn't receive that treatment, then that's a controlled clinical trial. So what to look for in the method section? So related to the subjects, you want to look at the inclusion criteria. Who's included? It describes the population as to how they selected the subjects for the study. And you want to look to see that this group is similar to the real-world population that you want to apply this treatment to. You want to look at the exclusion criteria, and exclusion criteria usually help to make sure that the study group is homogeneous. They want to exclude patients who might have adverse events from the treatment. They want to, so anybody who the treatment would be dangerous for, potentially dangerous, they would exclude. Anybody with other medical conditions that might interfere with the ability to tell the effect. Somebody who's too sick, somebody who's not compliant, they would want to not include in a study design. However, the real world population doesn't only have one disease, they're not so homogeneous, and so when you're reading a study, you have to try to look at the inclusion-exclusion criteria and see if this would apply to your population. You want to make sure you understand all the terms, that they're well defined. So if you were reading a study about COPD, and they said, we accepted all hospitalized male and female patients with acute respiratory insufficiency, would you know what they meant by acute respiratory insufficiency? No, not unless they defined what the term meant, how they were measuring acute respiratory insufficiency, because it could mean different things to different people. Also, you want to look at what the withdrawal rate is in a study. If the subjects had a hard time complying with the treatment, if the treatment was too toxic and subjects ended up withdrawing and leaving the study, and then how were the withdrawals handled? So if the people withdrew because the treatment was not beneficial and they just excluded them from the study and just didn't count them in any way at all, then it could lead to biased results. If the study had a lot of toxicity and people had to drop out, it's important to know that. So how the withdrawals were handled is important. The next part is how the treatment was allocated, and there are a number of different ways this can be done. By sample types, by paired samples, so that each subject in the study has one mate that's also in the study and in a different treatment group. And so they're matched as closely as possible. And then there's a separate sub-study type of this, which is a crossover design where the subject serves as their own control. So the subject actually gets both treatments. In order to negate the effect of one treatment on the other, it's best if there's a washout period, so they're not getting the treatment for a period of time. But this can be dangerous if the person needs the treatment. So it's not always practical to do a crossover design. In some conditions you can do it, in some situations you can do it. But if you see that, you want to make sure that there's been sufficient time between when the subject got one treatment and got the other, and there's no carryover effect. And also there's no learning curve of the subjects have to do some task or something where they would have learned something the first time they did it or had some experience the first time they did it, they may influence the second time around. Most studies are conducted with independent samples where the subjects are not matched as pairs, but you have large groups of patients who are supposedly similar to each other. And the larger the population in each group, the more the likelihood that they're going to be similar as opposed to dissimilar. And usually at the beginning of the results section, there's a table that shows baseline characteristics, and the important characteristics are compared for the two different groups. And you can tell if, based on that, the two groups were comparable. So you'd want to look at whatever the key parameters are for the study that you're reading about to make sure that the groups were evenly matched at the beginning. And then there's randomization. This means assigning the subjects to a treatment group by chance. If the investigator could choose what group each subject was in, there may be some bias. They may think, okay, well, you would benefit more from this one, or you're a little too sick to put you on this experimental protocol. We'll give you the standard treatment, and there's always a potential for bias that way. So a randomized clinical controlled trial is a way to ensure that there's randomization. So we also want to look at what the control group was. So there should be a control group in a randomized controlled trial. And you may read that the controls are historical controls. So historical controls might be used when ethically you can't have a non-treatment group. But this is invalidated by advances in medical care. So if you were to do, for example, a study on some cancer or AIDS, and you use as a control group patients 20 years ago, there's going to be a definite bias because the ancillary and other treatments that the patients would receive are very different. So, when you're reading about historical controls, it's often that you're limited because ethically you can't not treat, or there's no other treatment that you could give. The treatment seems so good, it's not, you wouldn't want to put somebody on something else. But if you're reading about historical controls, you want to make sure that the control group really would be a good match for the subjects in the study. What about non-treatment controls? Is this the same as having a placebo group? You just have a group that you say, we're going to give one group treatment A and the other group we're not going to give anything.
So you don't get the placebo effect.
Right. So what's the placebo effect?
They think they're getting better because
Right. So it's an effect of the therapeutic intervention that does not have any specific objective activity for the condition being studied. And it's not just the subject, but the investigator too. If the investigator knew somebody was not on any treatment, that would potentially introduce a bias when you're talking to the patient, when you're making observations, when you're deciding if you want to give rescue therapy. If you know the patient's not getting anything, you may be more likely to give them something. And it's especially the placebo effect is especially prominent when you have subjective symptoms. And so we often will use placebo controls in a study. And it's helpful. So for example, when I was a fellow, we were doing cold studies with the common cold. And there was one treatment we were looking at for symptomatic relief that we found a 40% reduction in symptoms with the symptomatic therapy, which actually we thought was pretty good. But then when we asked the placebo group, they had a 30% improvement in symptoms just from the placebo effect, that they thought this was a good treatment. So then it didn't look like the treatment that we were studying looked so spectacular. It didn't look so good. And then when you're looking at what the control group is, sometimes the control group will be standard treatment or the gold standard. So whatever, if there is already an established treatment for this condition, then the control group should receive that treatment, and you're comparing something new to that. So you want to make sure that this is really would be the standard treatment, what you would normally give the patient if there is an established treatment. And so you want to make sure also that the doses and the way it's administered is the same way you would do it and appropriate. Also, when I was a fellow, one of the drug companies had come to where I was a fellow and asked us to look at a new carbapenem that they were comparing to imipenem. And they wanted to use imipenem at a higher dose than we normally use. It was within this range, but it was at a high dose, and we knew it caused a lot of nausea and vomiting. We wouldn't use it at that high dose, but it was still an improved dose. And we thought, no, I mean, this is like obviously going to show that the new drug is tolerated much better. And we just said, no, we didn't want to do it. But if you didn't know that, if you were reading a study, and I don't know if that ever got studied and published, but if you were reading that, and then the conclusion was that our new drug is tolerated much better than this established drug, you'd have to look and see that the dose that they used was a dose that you would use. So, just be critical when you're reading the article. And then we want to look at also when we're looking at the methods section at blinding, we want to see if the study was blinded. Okay, and if it was blinded, was it a double-blind study, meaning that the subject and the investigator are unaware of what treatment the subject was getting? This is much more important when you're looking at subjective parameters rather than objective parameters. Was the blinding adequate? Was there an assessment of blinding? So some studies will try to query the subjects to see if they could tell what group they were in. And were the treatments matched as closely as possible, not just by taste or not just by appearance, but maybe by smell or whatever. If the treatment has a particular characteristic, you want to make sure that the placebo is matched for that same characteristic. And there's an example of how this can affect results from one of the first studies of zinc lozenges. So one of the first studies with zinc lozenges for treating the cold concluded that zinc lozenges are more effective in treating the common cold than placebo. And the study was conducted with zinc lozenges versus placebo lozenges. The subjects were randomized to receive either the zinc or placebo if they had a cold and they were enrolled in the study. And the design was that you would keep taking the lozenges as long as you had your cold. And then the investigators would measure how long the cold lasted. Well, the subjects in the zinc lozenge group realized that the lozenges tasted horrible, and they didn't want to keep taking them forever or until their cold was over. So they said their cold was over quickly. And the people in the placebo group just kept taking the lozenges because they didn't have any flavor until their cold was over. And this was one of the first studies that showed that zinc lozenges reduced the duration of the common cold. So it was a flaw in the study design because the placebo lozenges did not taste the same as the zinc lozenges. And the endpoint depended upon that. Then there's also a double dummy design. Anyone know what's a double dummy design? It means everybody who's involved is a dummy. So it's when you have two treatments so group A and group B are getting group A gets a treatment, group B gets a treatment, and they can't be given the exact same way. Maybe one is intravenous, one's a pill, or one's a liquid, one's a pill. It means that each subject will get one of each thing. So let's say one's a pill, one's intravenous. So in one group, The subjects get the real medicine in a pill and a placebo by IV, and the other group gets the other. So that it doesn't look as though, so it's not as though you can say, oh, the IV group did better than the pill group. You wouldn't know which you're getting. So they're matched so that it's a double dummy. So there's like a dummy, a placebo that each person gets. So also in the method section, we look at what the variables were, what the parameters were reasonable that were being looked at, that the observations were unbiased. For example, if you're looking at treatment of hypertension and the subject goes in there, walks up a flight of steps, sits in the room, and then somebody in a white coat comes and takes their blood pressure right away, there may be an effect of the white coat syndrome, of anxiety, somebody who's not well conditioned from walking up the steps, may be in a different condition than somebody who's exercises a lot. So the best thing would be to have somebody sit in the room quietly, maybe not even have a human being take the blood pressure, maybe have an automated blood pressure cuff take it so that there's no potential for the white coat syndrome. And you want to look at how the study was conducted in that regard. And then were appropriate statistical tests performed. So in the results section, the results should summarize all the pertinent data. You want to look at the beginning of the results section, the baseline characteristics. So usually the first table tells you how comparable the groups were. So whatever the important parameters are, you want to see that they listed them, or in the text of the paper that they describe them, where the sample size is large enough, were all subjects accounted for, how were withdrawals handled, did they just kind of sweep them under the carpet? You want to look at the numbers of observations, were they accounted correctly? Sometimes if you have time, you can count how many started in the study, how many finished in the study, and then what they describe about everybody. If you're looking at tables and graphs, in particular for graphs, you know ways to make things look bigger than they really are. Like if you magnify a little thing, it looks like very prominent and pronounced. So when you're looking at a table, just look, did they magnify it? Is it, what's the scale? Just to make sure that you're not looking at something and thinking something different than what they're presenting. Are the results of statistical analysis presented, and are they appropriate? Were all the research outcomes reported? And then in particular, you want to look at adverse events. You kind of wanted to see how many people didn't tolerate it, what they tell you about the side effects. So the discussion section contains the interpretation of the data and discussion of the clinical importance. So in the discussion section, you may see some discussion about the importance of the results. And it's important to know the difference between, and read what they're saying, between clinical significance and statistical significance. So if you're doing a study looking at 2 antihypertensive drugs, and you have 10,000 subjects in each group, you may find 1 millimeter mercury difference between group A and group B. And that may be statistically significant. And the authors may talk about this significant result. But it may not be clinically significant. Clinical significance is not a statistical term. It's even hard to kind of define what's clinically significant. It relates to what are the other options? How well is this treatment tolerated? What's the effect that you're going to see? Will the subject be compliant? How do you have to monitor them? So the clinical significance really takes into account your individual patient and not the statistical significance. Yes, it's good. You want it to be statistically significant. Okay, otherwise there may not really be a difference in worth changing treatments. But the clinical significance really relates to how it fits in the context of the patient, other treatments, the cost is, also. So that's something that the paper usually is not going to tell you. And then if the study finds that the treatments were not significantly different, it's important to think about why they didn't show a difference. Was there really no difference? Or did the study not have enough samples, did not have power, was not large enough to be able to show that degree of difference? We'll talk at some other point, or you'll hear more about power and how to look at that. But that would be a reason why you may find no difference between groups. One is there really is no difference, and the other is the study wasn't powered, didn't have enough subjects or enough outcomes to be able to show that degree of difference. So also in the discussion section, there should be a discussion about future research. Oftentimes it's the area that the investigators are doing further work in. But be wary of biased language in interpreting the results, biased citations, errors in statistical conclusions if you know enough about statistics, inappropriate study conclusions. So you don't want somebody who looks at something in one small condition and extrapolates it to like all vascular diseases, in any part of the body, something like that. So you want to just make sure that the conclusions are not overly broad. And then the last area to look at are, and this you can only really do if you know the literature, is the results section. It's the references section. So has the author considered work of others, and how comprehensive is the reference list? So if you're familiar with the topic, you might know that they're not citing other works that are maybe competing theories or different groups have a different explanation for something. If you're not that knowledgeable about the material, you're not really going to know how balanced the reference list is. And then the last thing which I want to leave you with is this handout, which asks a lot of the questions that we've gone through. So when you're going through a journal article, if you're critically reading it and you don't have a place to start, a framework to start, this would be one way to start to look at the article. There are a lot of ways to critically look at articles and a lot of places to start, but if you're kind of stuck and you can't figure out how to attack it, take out this piece of paper, and this is one way to kind of break the brain freeze. Any questions? Thank you. Any more air in here? One Colby's came about.
Yeah. And it was like it produces about 24 hours. So you guys look back. And
the Colby's is in the where is it?
It's of course.
In effect, your taste buds.
Yeah.
And you don't want to take it.
Yeah.
There's some negative.
Yeah.
It's a nice preset.
So that's mine is less than patient. I should run the.
You want my list of patients? I wasn't saying these numbers.
Like,
I get all your results this season.
Okay.
okay.
Hi, Dr. Baker. Sorry, I know you're going on vacation.
So I'm here.
I
Yes.
keep calling you.
Okay.
I'm
And
geriatric.
so,
Would,
they'll meet Berber, did at 8:30. Do they know who they should go to after
No,
that? The office will tell them, is there a contact person? he's loading tonight, he's not gonna be there.
Oh, well, the locations are also, we have the budget.
Okay, so they're gonna come on Tuesday. Monday, he'll meet Ronnie on Monday.
Does he know the funding?
Yes, he responded to my email.
Okay. Oh, I didn't see your email.
Yeah, I just sent an email, then I sent the email, to